Hello, and welcome to Two Peds in a Pod, the medical education podcast from the Children's Emergency Department in Derby. I'm your host again, Ian Lewins, one of the consultants there, and I'm really pleased to be joined today by Dr Alasdair Munro, who's a clinical research fellow in Peds Infectious Diseases. Good morning, Alasdair. How are you?
Good morning, Ian. I'm very well. Thank you so much for having me on your venerable podcast.
I'm delighted. So before we sort of crack on, what I was interested in actually reading is what's your job actually involve? You're based in Southampton, is that right?
Yeah, that's right. So I'm based in the clinical research facility in Southampton, and my job is a split of two things. So half my time is spent sort of supervising, helping run early phase clinical trials in children, so antibiotic trials and vaccine trials. And then the other half of my job is sort of time to develop my own research interests. And at the moment, I'm sort of working up a PhD application, which I'm hoping to start in the next few months.
Excellent. So the reason I sort of wanted to chat to you was there's a thread that you put together on Twitter, which is now, I think, currently sits as your pinned tweet,
Yes.
and it's at APS Munro, which was all about pediatrics and antibiotics and myth busting about that. And the reason I loved it was I read through every single one of those and thought, absolutely 100% could not agree with it anymore. So I thought we would sort of have a chat through those 5 myths today, if that's okay.
Sounds great.
Okay. So I really like myth number one,
Yes.
which often explains takes a bit of explaining to some people. And myth number one says all bacterial infections need treating with antibiotics.
Yes. Well, that is a myth. You're right. I think conceptually, this is something that is very different from I think what most people imagine, and I think particularly in children. And it makes sense why people would think this. Antibiotics are there for the express purpose of treating bacterial infections. So why wouldn't you? And I think what it boils down to is ultimately, I think sometimes we're totally sure actually what we're trying to achieve with antibiotics, in particular because a lot of the infections that we most commonly see in children would just go away on their own, whether we gave any antibiotics or not. So what
Yeah.
ultimately are we trying to achieve? And I think it's difficult to reassure people that there is an infection that you can treat and this is not necessary. And people just need a lot of reassurance generally that you're not going to change the course of the illness for most children, that complications of these infections are extraordinarily rare, and the number of children you need to treat to prevent these complications is enormous. So ultimately, most of the time, actually giving antibiotics to children for benign respiratory infections, even if they are bacterial, the antibiotics are probably causing net harm to most children, and that's really turning what people's innate beliefs are on their heads a lot of the time. And so I think this is one of the myths I sort of spend most of my time talking about to junior doctors and particularly people who are coming through pediatric rotations, not as pediatric specialists but maybe GPs and foundations.
Yeah.
Is that, well, yes, this child does have otitis media. Could it be a bacteria? Yes, but if we give them antibiotics, how are we going to help the child? And most of the time you're not. And so it's just about reassuring people that this is, it's a sort of a reflex habit that needs to just be questioned and needs to be thought about a little bit more.
And I think from my perspective, my practice, the classic example is the uncomplicated tonsillitis, which I know you've also been tweeting a fair bit about recently as well. Is people say, "Oh, this child's got tonsillitis, I'm going to give them antibiotics." Often I would say, "Why?"
Yeah.
And it sort of stopped people in their tracks slightly. Why are you giving antibiotics, given that they're almost certainly going to fight this infection off themselves?
Exactly. And the poll I did on Twitter, I think, showed really that people aren't that sure, or at least even if people are sure in their own minds, we're not all treating for the same reasons, which I think does highlight that there's a bit of a problem there. And part of this is historical, obviously, because in the past with tonsillitis, the reason for treating, and I think still particularly in the US guidelines, people get really funny about group A strep for good reasons, because it's
Yeah.
a nasty bug, and it's got this history of famous non-suppurative complications, which is primarily rheumatic fever, and that was why we were treating it in the good old days. But for whatever reasons, now the strains of group A strep circulating are not rheumatogenic. We almost never see cases of acute rheumatic fever from native UK children. And so really this historical thing of we must treat group A strep because we don't want children getting rheumatic fever for good reasons, it just doesn't sit anymore. It's just not really a valid reason for treating. But of course that practice has become ingrained, and so it's one that's sort of slowly being undone.
And from your perspective, what would be, somebody might say, well, okay, I kind of get where you're coming from. They're likely to fight this off, but parents are pushing for you to do something, and you want to do something. So, what's the harm in giving a short course of antibiotics?
Oh, yes, I do hear this a lot. I think this is another thing. Well, I mean, this should have been one of my myths. I think is that it's a myth that antibiotics are harmless, that antibiotics are a low risk medicine. And I think the problem is, yes, the immediate side effects of antibiotics are, they're not severe, they're not terribly pleasant. About 1 in 9 people get diarrhea, and there's hypersensitivity reactions and that sort of thing. But more and more now, we're realizing the really insidious harms of antibiotics exposure, particularly in really early life. And some of the recent papers in JAMA Pediatrics looking at medicines that affect gut dysbiosis, so proton pump inhibitors, H antagonists, and antibiotics are associated with a doubling of your childhood risk of developing asthma, atopic diseases, and stuff like this. And there's a whole host of research into the link with early life exposure to antibiotics and other conditions. And the more we learn about the microbiome and how important it is that we maintain this good balance with bacteria that are there to help us, the more we realize that perhaps eradicating all those things and sterilizing young children at an early age is not harmless.
And I think that's a really important message to sort of get across. Is I think antibiotics are often seen as, well, you might get a bit of diarrhea, but actually otherwise it's not a problem. And if it doesn't work, well,
Yeah,
so what?
exactly. Yeah. No, I think there's much more serious stuff at stake, and I think it's one of those things where you know you need to be sure that what you're doing is of net benefit to the child. And I think for the vast majority of cases, it's really not.
Okay, let's move on then to excuse me to myth number 2. That's saying, okay, there are some children who will need antibiotics, but myth number 2 says the following infections always need IV antibiotics, and you've included periorbital cellulitis, bacterial lymphadenitis, pyelonephritis, and pneumonia.
Yes. And again, this is something that even some quite senior people, I think, feel that some of these infections have historically, I think, have always been treated with IVs. But this is again another paradigm shift, that when you look at the studies and you compare success rates, and there are actually some amazing studies, particularly for pyelonephritis. The failure rates of oral versus IV are basically identical. So all of the indications are that unless you suspect bacteremia in a child with clinical pyelonephritis, there's really no reason to jump in with IV antibiotics, because at the end of the day, there isn't anything magical about putting an antibiotic into the vein. And most of the antibiotics that we use in children actually have really good oral bioavailability. You're getting 90 to 95% of most of these antibiotics into the bloodstream anyway. There is not a huge difference between bunging it into the vein and allowing the child to just swallow it if the same concentration of antibiotics ends up in the blood. And I think the other thing is that people, I think, worry a lot about children failing on oral antibiotics. And look, it happens, and it's not a big deal, because we've got a really good culture in pediatrics of safety netting. And when children go home, it's never off you go, we don't want to see you again. It's always, yes, you can go home, but here are the red flag signs. If it's not better within a certain amount of time, you need to come back. And so, I'll almost always treat each of those infections, periorbital cellulitis, lymphadenitis, pyelonephritis, and pneumonia, unless they've got complications at presentation or, particularly severe disease.
Yeah.
I'll always give antibiotics orally as a first line with appropriate safety netting, because, occasionally some of these antibiotics have some of these infections, are caused by slightly more recalcitrant bugs, particular strains of Haemophilus, for example, and they just won't go away completely. But the children come back, and it's safe as long as they've got appropriate safety netting.
Yeah, no, I completely agree, and certainly in my own practice, I've personally, in even the last 5 years, for example, seen quite a significant shift of moving much more towards using oral antibiotics as a first line. And I also think that people who come into our department, so people who've maybe rotating through from adult ED or people who are GPs, actually find that quite a challenge and quite a difference from sort of maybe their practice with adult
Yeah,
patients.
absolutely. And I think part of that is because in pediatrics, in fact, one of the things I actually like about pediatrics is because doing anything to a child is infinitely more difficult than doing the same thing to an adult. You actually have to really think, is this absolutely necessary? Do I really need to subject this
Yeah.
child to a cannula and, give the child IV antibiotics? And if you don't really have to, then you shouldn't be doing it, because again, it's about, net benefits and net harms. And with adults, it's easy to bung a cannula and give the antibiotics, and off you go. But I like the fact that we have to think harder with children and say, well, actually, look, most of these can just be dealt with oral antibiotics, so it's worth giving it a go.
Yeah, absolutely. And again, the important part of that, of course, is, as well as giving the antibiotics, is that the huge importance of
Yeah,
safety
absolutely.
netting. As you say, if it's no better within a certain period of time, you come back, or if the child worsens,
Yeah,
you
yeah,
come back.
exactly. Yeah.
Okay. Let's move on then to myth number 3, and we're back to tonsillitis
Yes.
again. And myth number 3 says amoxicillin cannot be used for tonsillitis as it causes a rash if the child's got
Yes,
EBV.
this is a great myth. It's a great myth because it initially came from some quite good studies in the 1960s, where people were seeing an association with giving, at the time, ampicillin for sore
Yeah.
throats, and then children who were found to have Epstein-Barr virus would come out with a rash. And some of these series were reporting between 90 and 100% of these children were getting this sort of horrible maculopapular rash. Now, we do know that children who have glandular fever with EBV will get a similar type of rash somewhere between 15 to 30% of the time. So we're not looking at this being, entirely down to ampicillin. But over time, what's happened is ampicillin has fallen out of fashion because it's essentially been replaced by amoxicillin, which it's an aminopenicillin but with a different structure. And since that's come into use, obviously we're still giving antibiotics to some children with sore throats, and some children have got amoxicillin. And in the more recent studies, actually, if you look at the rates of children getting rash with EBV, if they've been exposed to amoxicillin or not, it's basically about the same rate. You're getting the baseline rate of rashes. So, some children will still get a rash with amoxicillin and EBV, but they would have got the rash anyway just from the EBV. So essentially, this was a rash that seems to have just been caused for whatever reason by ampicillin. But now that we're not using ampicillin anymore, the same reaction doesn't appear to happen with amoxicillin. And so amoxicillin being infinitely more palatable than penicillin V, which, if anyone has ever tried liquid penicillin V, it is to be avoided at all costs. We're locally, at least, we're recommending that if you're going to treat tonsillitis with antibiotics, that you use amoxicillin, because essentially, I don't think a single child in the history of pediatrics has ever completed a 10-day course of 4 times a day penicillin V. So if you're going to bother giving an antibiotic, give an antibiotic that the child will take and hopefully complete the course of, and that would be amoxicillin.
Absolutely. I'm so pleased you said that, because I was challenged by that by one of our very good GP trainees on a couple
Yeah.
of days ago. And, I think I said pretty much word for word, do you really think that a child's going to take 40 doses of a disgusting
40
tasting
doses.
medicine?
Yeah, I
Absolutely no
mean, no,
chance.
I wouldn't. I can't blame the
No.
child. No, it's absolutely disgusting.
Yeah. So that's useful to know, because I mean, as I say, I've certainly, for those few children where I'm choosing to give antibiotics, I've certainly moved over to amoxicillin and away from Pen V, because the compliance must be, as you say, pretty much
Yeah,
zero.
absolutely. Yeah, yeah.
Excellent. Well, I'm glad we agree. This
Yeah,
is all
yeah,
confirmation
exactly.
bias. So, myth number 4, then, moving on. And I like this one a lot, actually. And I think this is a really important point. Myth number 4 says that broad spectrum antibiotics are stronger than narrow
Yeah.
spectrum.
This is obviously not a myth that's specific to pediatrics. This is obviously a very generalized thing, and you do hear people saying this to patients quite a lot. So particularly in inpatient medicine, we'll be switching someone over from a narrow spectrum to a broad spectrum, and you'll hear a doctor say, "Yeah, don't worry, we're putting them on an even stronger antibiotic,
A stronger antibiotic.
and the truth is that the spectrum of efficacy for an antibiotic is in no way inherently linked to its ability to kill, whatever bugs it is that are sensitive to it. And a really great example for this, I think, is for Staph aureus. So if you have a Staph
Hmm.
aureus that is sensitive to penicillin is the most effective bug at killing that strain of Staph aureus. So it will have the lowest MIC, so lower than flucloxacillin and lower than vancomycin. And the thing is, there's so many different factors to take into account for antibiotics. There's obviously, if you're not sure what you're treating, there's the spectrum of activity, because that's important. You want to make sure that you will be covering whatever bug it is if it's unknown. But even once you know the bug, there's that particular strain's sensitivity to what antibiotic you're using. There's the penetration of the antibiotic into whatever space you want. And some of the more broad spectrum gram-positive agents like vancomycin and teicoplanin, they will treat almost all gram-positive bugs, but they're dreadful antibiotics. They're just not good at killing bacteria, and they come with a whole host of other problems. But I don't think I've seen a child in a therapeutic range for vancomycin, in the last 2 years. Um, so the idea that if we just broaden the spectrum, that will just be better at killing, it's really not the case. It will kill a broader range of bugs, but for the particular bug you're trying to kill, broader is not necessarily better.
And I guess this is something that we continue to hear, really. And I wonder where this has come from, actually.
Yeah, I'm not sure. I think it's because I think it probably comes from treating patients who you suspect have infection. They have signs of sepsis or whatever, and you don't know where it's coming from. And so, if you start an antibiotic and the patient's not responding, what do? You broaden the spectrum of activity. And then the patient's not responding.
Mm.
So what do? You broaden the spectrum of activity. And I think that this sort of, gives you a feeling like, well, this antibiotic is better. So I've moved up to a better antibiotic, but what it really is you've just gone, oh well, it's not working. Perhaps there's a bug that's resistant to the antibiotic I'm using, so I just need to broaden the spectrum, slightly. But when you're going up from ceftriaxone to tazobactam to meropenem, if you've got a bug that's sensitive to ceftriaxone, you've not done anyone any favors by putting them on tazobactam or meropenem. And actually, but particularly for some strains of bugs like Staph aureus, going more narrow spectrum is better. So as soon as you've identified a bug like Staph aureus, you want that child on flucloxacillin straight away. You're not going to keep them on meropenem. Do you know what I mean? But this is,
Yeah.
again, that type of practice of it's not working, let's broaden it, let's broaden it. I think that just sort of gives people a feeling that the broader spectrum antibiotics are even better.
And maybe this goes back to, I think, something we discussed previously on Twitter about, are you giving it to make you as the doctor feel better rather than necessarily the
Yeah,
patient?
exactly. And I think there is a sense of that, this worry that you've missed something, have I missed a bug that's going to be resistant? But I think even on a more basic sense, there's just this feeling that you need to be on, quote unquote, the best antibiotic, and people feel that, these really broad spectrum agents are better, but it's often not the case.
Okay. And now moving on to the fifth and final myth, again, one I really like, which is something that's very much ingrained, I think, in people, is myth number 5 says you must wait 48 hours for blood cultures before stopping IV antibiotics.
Yes, this is a great myth, and I think
Yeah,
again,
yeah.
I think this is probably partially historical, and a lot of it's probably to do with the way that blood cultures have previously been reported, and so in the past it was someone going to a machine and checking it, or on a sort of regular basis to see if any bugs have grown. Whereas we're now almost all blood culture machines, used in microbiology labs have what's called continuous monitoring. So once the bottle is in the machine is, every few minutes is checking for a sort of an exponential rise in carbon dioxide, indicating metabolic activity of growing bacteria. And so the lab staff are alerted, at the moment that the machine has detected bacterial growth. The machine flags up a little light with that particular blood culture is, and so there's nothing magic happens at 48 hours. There's not a 48-hour check where someone goes, looks at the bottom, goes, that's fine, that's done, that's negative, the test is finished. Actually, most people keep those bottles on the machines for 5 days or more. So it's not like someone suddenly binned it at 48 hours and the test is negative. It's a continuously monitored test. So the 48-hour thing is partially, I think, a historical remnant, and just also because of previous studies that have looked at what percentage of blood cultures that flag positive are positive within 24 hours, 36 hours, 40 hours, whatever. And by 48 hours, you're at 99%, so pretty high. But really, we're not always looking for 99% of everything for every test we do, because you have to really think about your pre-test probability. And we still
Yes.
have a lot of protocols for children, like the child with fever and a non-blanching rash, or sort of febrile infants who still look well, but people feel funny, so we start them on antibiotics, even though no one really suspects they've got a serious infection. We do still treat a lot of children with empirical antibiotics with a very low baseline suspicion that they've actually got a bacteremia, and in which case waiting for 48 hours is really not necessary, because by 24 hours 90% of all blood cultures that are going to be positive are positive. By 36 hours it's 95%. So you're really getting very marginal gains by waiting an extra day or so, and often that's the difference between another visit to hospital if you're ambulating, another dose of ceftriaxone, and
Yeah.
You can take a very pragmatic approach to these sorts of things. So, uh, there's nothing magic about 48 hours. You just need to actually weigh up, the risk of the patient in front of you, and what did they present with, what were their other blood results, and have we found a virus, in their snotty nose since then?
Yeah.
And that there's no sort of golden gate that gets crossed at 48 hours. You can make a judgment based on the child in front of you.
And absolutely. And I think when you sort of stop and logically think about this 48-hour cutoff, it makes no sense
Yeah,
whatsoever. That's, as you say, nothing magic happens at that
no,
48-hour
no,
mark.
and it does. I can understand it, but it does still sort of give me shivers when people go, "Oh, the blood cultures aren't back yet." The blood cultures never come back. They've not, they don't go anywhere. It's going to be on the machine for 5 days. They're consistently monitored. The blood culture. If you've not seen a result, it's because they're still negative. They are negative until they're positive, and we just have an arbitrary thing where most labs will spit out a result on the computer by 48 hours. I mean, locally now, ours are giving results at 36 hours to try and change,
Right.
this sort of historical thing about 48 hours. And actually, we're making a move to say, if you're not that concerned, it is fine to stop at 24 hours. You can review the child, if you've ambulated them the next day, or review them on the ward round. And if the cultures are still negative at 24 hours, if you feel safe, just stop. It's fine.
Okay, and I guess that the bottom line, the thing that draws all these myths together, is really trying to improve antibiotic stewardship, isn't it?
Yeah, absolutely. And it's a real passion of mine because, Ian, I love antibiotics. And what I would really love is for antibiotics to keep working, to keep being useful.
Yeah.
And we've got this really sort of fantastic but also slightly troublesome paradigm in pediatrics, where we have the most incredible set of vaccinations which have all but eliminated some of the scourges of infant mortality in the past. It's just so rare now to see meningococcal meningitis or bacteremia in children.
Yeah.
Haemophilus influenza B. I mean, I don't think I've ever seen a case of invasive Hib infection in a child. Epiglottitis, it has basically disappeared, and pneumococcal vaccinations are so effective now. So we've reduced the amount of these really, really serious infections significantly, precipitously. But at the same time, there are still some children who get sepsis, and it's really hard to find them. And there's a whole host of stuff now about sepsis awareness, and we're constantly being told to think sepsis and do a sepsis trigger tool and all this other stuff. And so it's really hard to not give antibiotics when you're being told all the time you must think about sepsis. This child could have
Yes.
sepsis, and that, and that's right. And some children look fine, and later on they get really, really sick. But most children who look fine are fine, and we can't treat all of them. And so we have to balance this up against this sort of global emergency that we have with terrible antibiotic resistance that's becoming progressively worse. And we're now seeing cases of carbapenem resistant Enterobacteriaceae in the UK. And this is a real problem because I'm actually involved in some of the trials for these new antibiotics in the UK, some of the gram negative sort of carbapenem sparing or saving drugs, and there's not that many of them. And if we don't get better at appropriately restricting antibiotics, or just giving them when it's of net benefit to the child, we're soon going to be in a place where you can die of sepsis from cutting your wrist, from a routine surgery, and that's not a good place to go back to.
Absolutely. And I think, we all have, as you say, we all have a responsibility to do this. And hopefully, by doing the myth busting work that you're doing here, that will continue to improve.
I hope so.
Alasdair, thank you so much for that. That's been fantastic. I think this has become an absolute must-listen podcast. And thank you so much
for
for your time.
having me on. It's a real pleasure.